about by looking at this slide. But what I've started to do is like show pictures because I think it's a little bit more fun. So these are some of the skylines of cities that I've lived in. And what you'll notice is each skyline's different, but every place has something to offer and it's relatively beautiful. And in each of these cities, the populations that I've worked with and the communities that I've built relationships with and done research with have all looked relatively the same. And these are all actual pictures of neighborhoods in St. Louis, Atlanta, Miami, and Providence, respectively, that I've worked with people from those communities clinically and with research. And so what you'll see is in each of these cities, there are parts of the city that are shiny and bright and fancy, and then there are parts of the cities that don't get those services and don't often have access to the healthcare or behavioral healthcare needs that they might have. So just a few questions to kind of get thinking about today is just thinking about the communities that you work with and maybe populations that you have experienced, working with clinically or in research that you would identify as multiply marginalized. How might they experience physical health or mental and behavioral health? And what are some of the challenges they have in engaging in our healthcare system? What can you do to help close the gap and meet those patients' needs? So I'll just kind of plant those seeds as I start talking. So talk a little bit about HIV-affected communities. When I say that term, I mean broadly communities that are disproportionately affected by HIV, which includes people who have experienced incarceration, people who identify as ethnic or racial minorities, people who are LGBTQ or belong to the LGBTQ community, people who have maybe experienced drug use or addiction, and really the intersection of a variety of these populations. What we know is that within the US and really globally, the majority of folks who are newly infected with HIV today are experiencing some level of multiple marginalization at sort of an individual, interpersonal level, but also at a societal level. And they have experiences of discrimination that are very real and felt. They also often carry internalized stigma as a result of some of those identities, shame, trauma, and I'm thinking like criterion A trauma that occurs across their lifespan because of some of those, other sort of external factors. Challenges with the medical system, and honestly, sometimes really bad experiences with the medical system. Challenges maybe advocating for themselves and what they need. And then, having difficulty once they've been sort of excluded or marginalized in some way, whether it's incarcerated or struggling with addiction or homelessness, it's like maybe hard to rejoin or sort of become part of mainstream societies again. So my approach to this work has always sort of been to think about research and programs with communities, not on them or for them, but really partnering with people and figuring out what they need by asking them. So sometimes, in research, we get quantitative data, but we can still ask questions that are meaningful. And then other times we literally get their voices and ask them in qualitative interviews what they think and what they need. Identifying gaps in existing care models, and then suggesting solutions that directly address those clinical needs based on what they're saying would be helpful for them. And I think this is always how I've been approaching this work, and I have a picture from as early as graduate school, my dissertation project. So I had an NIH-funded dissertation fellowship, or an F31, where I looked at people living with HIV and their issues or challenges with their sleep, which is something that's been documented in the literature, but is not well understood, and then how their poor sleep or insomnia led to health outcomes. And as part of that grant, one of the things I wrote in the end was that it was important to me to share the data that we collected and the information that we generated with the patient population that we recruited from. And so this is me on my internship year. I flew back down to Miami, and we created these little pamphlets that I'm holding that had a summary of the data findings in simple language with pictures and graphs. A lot of the participants hadn't finished high school, so we wanted to make sure it was easy to understand. And then sort of like the take-home messages of what we learned. And rather than sort of giving them to people who had participated individually, we placed them in the clinic so that anyone in the clinic who wanted to know about sleep and how it affects their HIV health could pick up a pamphlet upon leaving and read about it. So I think this has always been sort of how I've approached doing research, is really to think about why are we doing this, who is it for, and how can they directly benefit, not 10 years down the line or 20 years down the line or some other population, but how can this group actually benefit from what we're learning. And I took that into my work as a research professor. So one of the things I was doing sort of early in my career at Brown was partnering with a community-based organization in Providence that provides outreach to street-based sex workers that work in the city. Often these are also folks who are experiencing severe addiction and homelessness and are quite literally staying on street corners or under bridges. And I provided like low barrier mental health care at their drop-in center, which is pictured back here. And during that clinical work, a lot of the like street workers were basically saying that when they were going out to places to provide supplies and services, a lot of the efforts that the city and the state were making to address COVID-19 weren't reaching people who needed it the most. And so all of these things like, tax breaks or rent relief or things really don't matter if you don't have a place to stay or you don't have, basic needs. A lot of the food pantries had shut down, and certainly places that served hot meals had shut down. And so what we did is we did this like brief survey. We paid people $5 McDonald's gift cards, which the peer specialist gave out, and we asked them about what their needs were. And they answered maybe 10 questions, one of which was 1 or 2 are open-ended, qualitative, sort of people wrote down what people were saying in the field. And we ended up actually providing this information to the Rhode Island Department of Health. And the result of sharing the information that we gained with them was that they actually set aside funds for people who are not filing taxes. So basically this kind of population to be used for things like food and cell phones and hand sanitizers and masks. So it directly, I want to say within like a month of analyzing the data, we went to this meeting and basically said, here's what we found, do something about it. And they did. And just sort of sharing them, one of the main findings was when we asked people about the impact that COVID-19 was having on their lives, you could see most people said a moderate or major impact. And then we were able to publish the findings in a journal later on. I also worked on a project where we got pre-exposure prophylaxis, or PrEP, which is an HIV prevention medication, into the local jail and prison system in Rhode Island, which is something that historically has not been offered in jails and prisons because the routes by which people acquire HIV, like sexual contact and drug use, are typically prohibited or forbidden in carceral settings. And so often they don't offer this medication, but we do know that people still engage in those activities in the prison system. So this project was really trying to get that available, I guess, to folks and really thinking about what people wanted while they were there. And what you'll see is that many people had a lot of barriers to actually being engaged in PrEP care, but there were a good number of people who were interested and wanted this service. And so that continues today. So now if you are incarcerated in the state of Rhode Island and you would like an HIV prevention medication while you were there, you're able to be started on it there, which is pretty impactful. So those are like a smattering of other experiences, but today I'm really going to focus on a developmental award that I had that looked at prevention of HIV in young Latino men. And so this will be sort of a deeper exploration of how some of the research like concepts and backgrounds were applied to a population that often is at high needs, but is currently underserved by our existing medical system. So I'll pause now. Are there any questions before I continue? And I seem to have lost your picture, so just feel free to chime in. Anyone? Okay. So Project PrEP Ideal. So this project was focused on young Latino men, as I said, and these are some of the Instagram ads that we had to recruit folks, but was really focused on increasing delivery and engagement among Latino men in PrEP care. And I'll talk a little bit about the questions we asked and what we discovered. So during my clinical internship year, I was at the Miriam Hospital HIV clinic for a year, which sees a variety of folks living with HIV. Rhode Island is a very small state, so most of the HIV care in the state is actually delivered by one clinic. And one of the things that started to happen is that I was meeting with a lot of people who were newly diagnosed with HIV, in part because the existing attending psychologist was seeing people and had been seeing people for years who were existing patients, but the newer patients hadn't had someone, so the psychology intern was the perfect person to kind of take them on for the year. And often I was actually getting these referrals while someone was in distress from their new diagnosis. So this would be like a nurse sitting down with a patient, telling them about their HIV disclosure, and then that patient immediately starts to cry and is like, I want to kill myself. I don't think I can go on. And then I would get on my door and it'd be like, hey, I have someone for you to meet with. Can you help them? And most of these men were young. They were under 30 years old. And what was interesting to me as someone who studies health disparities and really has focused my research career on projects that address that or look at that or come up with interventions to try to minimize those gaps, was that most of the younger white men who have sex with men, so gay, bisexual, or other men who are having sex with men, had been on HIV prevention medication before. And largely the gaps in care that they had were due to things like serious mental illness, so bipolar disorder or otherwise, or severe addiction issues that made it harder for them to engage in care. So maybe they were on a medication, but they forgot to go to the pharmacy, forgot to get a refill, had a manic episode, stopped taking all of their medications, and PrEP was one of those medications, and seroconverted or became HIV positive in that time between when they had last filled their prescription and when they were getting new medication. And what was very different is that the young Latino men mostly had never been on PrEP, had never been offered a medication to prevent HIV, had not known where to seek it, didn't realize that the other side of the clinic actually had a PrEP clinic operating there. And that was really interesting to me because demographically, this population was a restricted age range. So sort of this young professional, mostly all of them had access to health insurance and healthcare. Many of them were working young professionals. And yet there was still this pretty significant disparity that we were seeing. And I just couldn't give up on asking why. And I think you'll see through just how I am, that's just the way I think about things. It's why is this happening? And so I had this research idea. And when I became a faculty member, I applied for what they call a developmental award to really study this and better understand the phenomena that I was observing in clinic. So a pitch to all of you as you're doing clinical rotations and in different settings, be paying attention to what your patient population is saying to you and perhaps pursue funding to learn more about that. So my research questions were, why were Latino MSM engaging in PrEP care at lower rates or lower, had less access than white peers? And what potential implementation strategies could be used to improve gaps in PrEP care and engagement? So I'll tell you all a little bit about HIV pre-exposure prophylaxis. So basically, historically, there was really behavioral HIV prevention, and actually a lot of psychologists and really health behavior change health psychologists have been behind a lot of those projects and work. Maybe some public health people with more of that health behavior change. But really, behavioral HIV prevention is exactly what you would think it would be. It's knowing your HIV status, knowing your partner's HIV status, using condoms, having conversations with your partners, making changes in sexual behavior to accommodate for HIV, things like that. And in 2012, PrEP came on the market, and it really changed that conversation because it allows for another layer of protection or HIV prevention. And so even if people are doing all of these things behaviorally, we know that sometimes things aren't perfect and people still end up with HIV. And so PrEP now has turned into a few different options. People can take it daily as an oral medication, or they can take it before or after an event. So if they know, for example, they're going on a date later that evening, they can take 2 PrEP pills before and 1 24 hours later and 1 48 hours later, sort of around an event or a sexual event. And then now there's an injectable form of PrEP, and there are still more and more that are being discovered. But what's amazing about this is it allows someone who thinks they might be at risk for HIV to use something protective at a biological level. And so the best way to understand this, if you're not as familiar, is sort of like contraception, where yes, condoms can work, and also many people choose to be on a different or additional form of birth control. Similar idea here is that it offers more options to people as far as HIV prevention. If you look at this, you'll see that in 2012, when it first came out, you had little spots of areas picking it up. But by 2022, you see there's like pretty good adoption. Similarly here, you'll see actually across all racial and ethnic groups. So if you look at the left side of the graph, you'll see that there's good adoption among all groups. However, what you will see is that the PrEP to need ratio, or the number of individuals in that group uptaking PrEP compared to the amount that need it, is significantly higher for white individuals, if you look at that orange line, than it is for Black or Hispanic individuals. So again, showing that maybe there is an upward tick in adoption, but that there's a difference and likely a disparity in what is being accessed compared to what is needed in that population based on HIV base rates, which are different based on racial group. So Rhode Island, it was relatively similar. Nice rate of adoption. If you're looking at this, you're thinking we're doing pretty well with getting people what they need. And if you look at the data from AIDSview, you'll also see that most of the folks are men. They are not evenly distributed by race, and it's important to know that most of Rhode Island identifies as white. So the fact that there are such high rates among Black and Latino individuals means that there are more per population being diagnosed, and that most of the people using PrEP are white in the state. So again, that PrEP to need ratio is significantly different. So I'll talk a little bit about the methods of this project. So the study team included a very wide array of people over the years. So we had people at sort of all different levels of their training, and who identified sort of across the racial ethnic groups, and as well as LGBTQ, who helped inform some of the methods, some of the advertisements that we used, some of the ways that we talked about or wrote the interview guides. And so that was really helpful to have people sort of with lived experience or shared lived experience to the population we were working with. And then, you know, our timeline was affected, like most things, by COVID. So we kind of started and had a slow start, but we're able to finish collecting our data within 2 years. And it was a mixed method, sequential, qualitative, and quantitative study. And I'll talk a little bit about social media because it was kind of fun. It was a slow go at first, but it was really interesting to see that we did gain organic followers who we encouraged to send direct messages and like engage with us and learn more about the study. And we also had other messaging that we thought would be relevant. So even if this person started following us and they didn't want to do our study, they can still learn something cool. So we had 10 days until the new year. And I will say this is an undergraduate did this work. It's pretty good. And basically every day of the week, like December, whatever that is, December 20th to like January 1st, or sort of that 10 days right before January 1st, every day we posted something new about health. And so people following us could see and reshare our posts. And we specifically followed like other public health pages and other pages in the area that were doing similar work, so that maybe some of their followers would get a repost of our work. It was kind of an interesting way to get the word out about what we were doing. Then this is one of our community-based research explanations. So we said, we want to hear from you. You are the expert and the one who knows best about your community. Help us think of better ways to improve PrEP adherence and engagement in Rhode Island. And then we had the same message in Spanish below. And then similar thing, we had what is community-based research, which again explains what that is. And how they can become involved and really ask them to be a participant in the work. And then here's one of our other ads, again, English and Spanish. Okay, so Qualitatively, we recruited a lot in clinic just because it was very hard to get folks who had never met someone or seen someone in person on the study team to want to talk to us via Zoom, which is how we had to end up doing it. And we were able to conduct it on Zoom, and people filled out a little brief survey, sort of like their age, their background, country of origin, maybe 10 or 15 questions. And then they did a little interview with us on Zoom, and for completing it, they received a $30 Dunkin' gift card, which if anyone's, I mean, this is like a joke, but it's true. If anyone's ever been to Rhode Island, there's a Dunkin' Donuts like within a mile or less of anywhere you are in the city. And it's like a very valued thing. So people were very happy to receive their Dunkin' gift card. And we actually had people pull up their cell phones while talking to us. And we sent it and made sure it landed in their phone before we finished the interview. So our guide was really based on, or sort of designed with in mind, like these concentric circles, this sort of Bronfenbrenner model where there is an individual, but that individual is really nested within other systems that affect how they feel, how they make their health decisions, and what might be influencing their decision making. We offered the guide as well as all the consent forms and everything in English and Spanish. And our STEM questions really asked about their family and cultural background and raising, so a little bit about who they were, different educational settings they'd been in, and other peers that they had, whether they attended school in their country of origin, if they hadn't lived in the US or here in the US, individual level of factors that related to HIV risk and acquisition, their knowledge and experience with PrEP, and any ideas they had for other people. And this was really interesting because what we discovered as we were doing the interviews is actually our participants tended to use other language. So they didn't want to talk so much about their own experiences or why they may choose to do something or not. They did a little bit, but they very frequently use language about other people. Well, some people might not want to do this because, and so we actually ended up modifying how we asked the quantitative questions to be like, what are some reasons you think people might not be interested in taking this medication with intention, to sort of reflect what we had observed in the qualitative interviews. And our sample was fairly diverse. So although all of them identified as Hispanic Latino, with regards to race, they identified across racial groups. Sexual orientation was actually fairly diverse, with a portion identifying as gay, bisexual, and then pansexual or other sexual identity. Most of them did speak English at home, and a good portion also spoke Spanish at home. And a variety of, educational backgrounds, insurance. Most of them were insured because they'd been recruited in clinic. We did end up including a small group of people who were HIV positive, which I'll talk about in a little bit and why we did that. Whether they were currently taking PrEP or not, so you see about a third were currently taking PrEP, and then with regards to income. So what we started with was thinking about asking people who had not been on PrEP, like, why haven't you been on PrEP? What's affecting your decision to take it? Do you have access issues, things like that? But what we started to discover is we were missing the other side of the story, which was someone who maybe hadn't taken it and had become HIV positive. And so we ended up, expanding and allowing for inclusion of that population as well. So here's a little bit about the qualitative data and what folks said. They basically said that the social context in which they lived was often not safe or affirming for them to express who they were. And that makes it really tricky when the medication that you're seeking is actually related to sexual behavior and identity. So this one young person said, I don't perceive my family as being accepting of gay people. They're in the love the sinner, hate the sin. And so he's not going to be out. And in fact, he's not generally out to too many of his friends. We had people who didn't feel like they belonged to the Latino community, so they sort of felt isolated from their own ethnic group. So this individual said that being Latino has impacted me in a way that isn't what you would think. I'm uncultured, and a lot of Latino men look at me like, you don't speak Spanish, you don't eat Spanish food, you don't do this. Kind of makes me feel bad about myself, and I feel left out of my own culture. It sucks. And then a large number, and this sort of talked about the ideals or values that Latino culture holds and the ideals and values that sort of the queer community holds felt like often they were at odds with each other. And so this individual sort of talks about Spanish language media often feeling like they never talk about sexual minority folks or really like recognize that's even a part of the population. And then I'll briefly touch upon some of the implementation strategies or things they thought we could do to address gaps in care. So not surprisingly, people felt like they wanted the providers to be warm and know about how to be culturally affirming. So this individual says, I do think there's something to be said about how you foster a kind of ecology of like warmth and kindness. It can look a lot of different ways, personable staffing, and I think, you know, culturally affirming or competent staffing. I think that's also important. People wanted prep materials that were not only linguistically compatible, but also culturally resonant. So this person said they want to be able to read materials and say, oh, this is somebody I can talk to who understands where I'm coming from. And that sometimes when materials were translated English to Spanish, that piece was sort of lacking. And then this was sort of nice. They felt like information should be available everywhere that you might be meeting someone to have sex or that would put you at risk for HIV. So this individual's like at clubs too, little pamphlets, anywhere you might meet someone, places you might meet a partner and have sex. I think it needs to be on dating apps. I think all the apps need them, be posting them, definitely doctor's offices and maybe even peer support groups. So this is again sort of at summary level, but they had these like really interesting ideas. So one of the things that people said is that social media and social media influencers actually have a really big impact on people because they're following and they have a lot of followers. And so they recommended that researchers and clinicians partner with influencers. And this group up here are Katya and Trixie, which I learned about actually from a participant who do like funny skits on YouTube and they felt like would be good people to promote PrEP. They felt like communities should be partnered with clinics. And so if you want people in this population to trust you and to want to come to your clinic, you should be partnering like actively with them, going to events in the community. Education about status. So today, because the HIV medications that exist are so good, people living with HIV and taking their medication as prescribed actually are not likely to transmit HIV to their sexual partner. And they felt like that is just good destigmatizing like information for everyone to have, so that even if someone is considering whether they should take PrEP for a partner or not, that overall everyone should feel included in this conversation. Like you can be on prevention medication, but also if you're living with HIV, you're going to be fine and you're going to be able to have like a healthy, you know, life, romantic partnerships, etc. They wanted providers who knew about PrEP and were LGBTQ affirming. They wanted, like I said, sort of tailored educational pamphlets that were linguistically and cultural tailored, and they wanted information available everywhere. And this is a cute little ad, feeling frisky, PrEP makes sex less risky. This is actually from a website that provides peer education and navigation for PrEP. And that was one of the things that people wanted to see more of. Like if they're just looking up information online, could they see an ad there? Would there be a linkage to care there? And then we took that qualitative information and we actually generated survey questions from those data. So questions on our survey reflected the comments that people had made. And that was really cool. The other cool thing that we did is we had recruited from this clinic area, and the clinic actually serves sort of the whole state of Rhode Island and then parts of neighboring Connecticut and Massachusetts. So what we were able to do with advertising is do like regional blast to that catchment area, so that the population that we were recruiting online actually matched the clinic population as far as like local and regional area. We used Google Analytics to distribute the survey to individuals who sort of met certain criteria. And we wanted to collect responses that could quantify some of the information we gotten qualitatively. And that's a plug for Google Analytics. Very, very effective online marketing. The one snag we ran into is that We did have a lot of women, although the survey was clearly, we tried to be like inclusive of gender identity across the spectrum. And as a result, for some reason, we had several cisgender women decide to take our survey. So we have a lot of beliefs from them about what people should be doing. But again, the target group we're really looking for is sort of sexual minority men. So that was sort of interesting. And then they were compensated for their time. So yeah, this is like, we had 200 people participate, but only 98 of them sort of met our definition or criteria of men who have sex with men. So I'll just point out, this is like hot off the presses, our paper just came out, but I'll point out some of the ones that I thought were interesting. So again, fairly diverse sample. You'll see just by looking down the columns on the left, like we have good distribution across race and sexual orientation and languages and level of education and all sorts of things like that. And on the right, you'll see that there was like a decent amount of PrEP experience. So overall, 67% of the sample had taken PrEP before. And that was sort of interesting to me because, again, the idea for the research really came out of this idea that there was unequal access or uptake. But then you'll see people were able to identify the reasons they had maybe stopped taking medication, and quite a few had reasons they had stopped. And then, you know, their considerations about other forms of medication. You will see, though, like, do you know anyone who's been on PrEP? The question right before. Only 58% individuals said yes to that, and that seems relatively low compared to what I would expect. And again, in a population that's at risk for HIV, and again, where PrEP has been pretty good uptake. So that maybe does indicate that there's some sort of disparity between white MSM and Latino MSM. And then these are some other interesting ones. This one, I think, has a lot of implications. So the question we asked was, although PrEP is now available in multiple forms, pills and injectable, many people still do not want to take PrEP. What are some of the reasons you think people do not take PrEP? And half of them said they don't know where or how to get it. And another half said their doctor has never recommended they take PrEP. And again, these questions were generated directly from some of the information that we gathered from the qualitative interviews. And so these were reasons that people had told us, but to see almost half of them didn't think people knew how to get it or weren't going to be offered by their primary care provider is pretty concerning, given sort of the at-risk population. Stigma came up for a good number of them. And then which of these ideas do you think would be most helpful for encouraging other men who have sex with men to consider PrEP to prevent HIV as part of their ongoing health? And what you'll see, and what I really want to highlight with this is all of the reasons that were provided to us by qualitative interviews were well liked by the larger sample who completed the survey. And you'll see that almost every one of them had multiple people who endorsed that item. And what was really interesting is we had like an other don't know and no one said that. So all of the quantitative survey fit into what these 15 men had shared with us in these original interviews and their reasons that people, or their ideas, which was pretty amazing to see. And then we created this like cool little table where we looked at barriers and facilitators of taking PrEP, and then different implementation strategies that could be trialed, and then maybe like what that would look like in practice. What was really neat is I had the opportunity to present parts of sort of what I'm presenting to you with the group of people who funded the project through the Center for AIDS Research and in Providence, like I want to say 4 or 5 months ago. And what was neat is the person for the state of Rhode Island who does HIV prevention, so sort of the Department of Health representative who's like in charge of HIV prevention for the state, was sitting in the audience. And after I presented this work, he came up to me and said, you know, like, we'd really love for some of these things to actually happen. Like, we know that this is true and you've documented that it's true. Like, let's figure out how we can get some of this change. So that's cool. More to come on that. But I'm pretty excited that person was there and that there was a group of people willing to sort of hear ways that we can improve. So my take home from doing this work, and something that I've always truly believed, is that the communities that we work with do have knowledge about their own health and how to improve services. And I think that needs to be balanced with our, professional knowledge, because we do go to a lot of schooling and have a lot of training. And often they do sort of know about what the issues are, or how things could be better. And the other takeaway is that if you look at these big data, and I showed you these like graphs where things are going up, it looks good. You can often miss like the bigger picture, or the picture of what's happening on the ground for certain populations. And we all know data can be misleading, and it can be interpreted different ways. So it's always important to sort of look at like the bigger picture of what's happening. In this case, the public health data looks good, and the clinic data looks good, but there are people who aren't making it to clinic, and those people may not be captured in those data. And so it's always important to engage sort of community folks, whether it's through surveys or otherwise, to participate in research to get their feedback. And then really thinking about how to develop strategies to reach folks, and using people from those communities to develop those strategies to improve health outcomes. This is the article that covers sort of what I shared with you today. And then I just want to thank our participants, and obviously the funding agency, for their work. And now I just have some time for us to talk about, go back, and I'm gonna pull your faces up so I can see you and I can reshare anything. There you are. Cool. So let's see, how can I share again, but also see you? Okay, yay. So I'm looking at some faces and some squares. Anyone? Hi.
Hi, Dr. Rogers. I'm so sorry that I got caught in traffic.
Oh, that's fine.
Caught the end of your talk, though. Thank you so much for sharing that really wonderful body of work. And I will try and break the ice and ask one of our psychology students to think about the talk and maybe volunteer first to ask Dr. Rogers a question. Who's ready?
I don't have a question yet, but I'm really blown away by how you were able to engage the community, and then by actually disseminating your work and the findings, you're able to connect with folks who are in decision-making seats, who can actually help use this work to then implement it on the ground. And that is so powerful, and I think should be the goal for research. We can really be at that intersection. And so it was just really cool to hear you share your work and your motivations and where it's going. So I'm excited for the project.
Yeah, thank you. Yeah, I don't know that it's super typical of everyone to do that. I think it's the way that I'm trained, but also a little bit the way that I am, that the gap that exists between research and practice feels so unfair to me that I just keep being like, can we just give it away for free? And so if people are willing to listen to me, I will gladly talk their ear off about ideas that come from research. And I think if you're engaged in research, it's always good to just keep that in mind. Like if you were in an elevator stuck with a decision maker in policy, what would be like the one thing you'd want them to know about your research that could make a change for people? And I think I'm lucky that in Rhode Island, that's a very small number of people. I now work in Boston. It's a great number of people who are in those, and it's a little bit harder to find who can make the change. But I am finding they still exist. And so if you kind of get someone who has enough influence and power, and you're like, hey, you know what I think would be a really good idea? Sometimes they're surprised. They don't know. They don't have those skills. They have a different set of skills, right? And I actually feel like I heard that once at a conference when I was a second-year psychology student, and I didn't understand what they meant. I really didn't. I listened and I was like, but I get it now, because it is true. Like a lot of those policy people don't know what the needs are, and they're happy to go to constituents and try to figure out if this is something that the people want. But yeah, thank you for noticing that.
I'll follow up with a question. it's amazing to see really, public health informed work that really does, include the community and bigger picture policymaking. And I asked this of our last speaker, and I'm curious your thoughts too. If you had all the decision makers in a room and could get them to magically pass a law or make a policy that would support the folks that you're serving with your research, what would you want them to do?
Yeah, I mean, I think that a lot of that's a great question. And I actually had to pause for a moment because there are immediate things that I think affect people, like housing, right? And that maybe aren't like directly related to the research, but can kind of come out of it sometimes. And access to behavioral health care, which seems limited and hard and high barrier sometimes. But I think the number one thing as it relates to people with HIV is that a lot of the NIH funding is still tied to HIV health outcomes, which is a really outdated model. So HIV went from being like an infectious disease that, had death implications within the first 10 years, that someone was diagnosed. And now it's really a manageable chronic illness for most people living with the condition. And yet NIH almost always requires, and not just NIH, even like funders like SAMHSA and stuff require the HIV viral load. So like how much HIV virus in their body be an outcome of research. And that often inclusion criteria for studies and for programs funded by things like SAMHSA or the AIDS Foundation are like based on very biological markers, and we have much better medications today. And so a lot of those things have nothing to do with, like, you could still have a stimulant use disorder and have your HIV under control and still be struggling, right? You could miss your medications for a week or two and not have any other symptoms. And so I actually had the opportunity to be in a room with people who had funded a project, and I basically told them that. And I said, like, I think this is really outdated, because what you're saying is their behavioral health needs are hinging on this physical health outcome, and that's not true. We have a lot of people who are more impaired by their behavioral health, who are living with HIV, than who are like overwhelmed by their HIV. They take one medication and that's it throughout the day. That's very different than how it was. And so I think, like, I'd love to see a reprioritization of what outcomes need to look like. And specifically, when you write a grant, there's like the primary outcome and the secondary outcome, and really thinking about, like, for any population, whether it's them or it's people with diabetes or whatever, it not having to be like this health marker that's a little bit arbitrary, when there are so many quality of life things that could change and improve, or like depression outcomes could change and improve, that we can also make those the focal point, and not always be so overwhelmed with like including this other thing. And sort of related to that is a lot of mental health research on like sexual minority men or LGBTQ men, like, forcibly includes HIV as a component of the treatment, even when those treatments are only focused on anxiety and depression, because it's like, you can't talk about that without talking about HIV. And I just don't think that's true anymore. Like we're like forcing things together for funding reasons, or for like these archaic medical model, which like doesn't always fit people's experience of things and doesn't always get the best research done. So
that is an awesome answer. I would also love to see that reprioritization, right? That like mental health outcomes on their own, psychosocial outcomes on their own matter.
Yeah. And sometimes even like symptom, what are we talking about? Like a 5-point symptom reduction. Much more important, like, this person got a job, they were able to pay their rent, like they're functioning again. Those are treatment outcomes. And like in the real world, those are really important treatment outcomes, so I would love to see that. But I think sometimes again, like, they're a little bit siloed, like these are different people, and they speak a different language a little bit. So it kind of reminds me, I don't know if you saw that article with Tom Insel, like once he retired from NIH, but basically it was like, for those who didn't see this article, basically said that, for years, NIH funneled a lot of research into understanding like the brain science, as if that was going to be the treatment for mental health conditions. And what they discovered was that while they were doing that, mental health in this country just got worse and worse. And someone sort of stood up in a setting that he was in one time and said, like, but my kid is struggling now. Like, you're talking about the chemicals in the paint, but my house is on fire. Like, you need to do something now. And I think that's just such a beautiful metaphor. And so I'm always thinking, as a clinician and as a researcher, like, where's the fire? Like, first put out the fire, and then worry about like the roof leak, you know. But like, we can't fix the roof leak if the house is on fire, right? And so yeah, I try to think about that.
Yeah, I love that. I also love the arc of Dr. like Tom Insall. He's now like at Google Analytics, right? And like living this data science life. And I think that there's, you know, such an appeal of thinking about like, can we get the biological mechanism, the biological marker of this, and just like reduce that value and everything will be okay, when we really know that people and mental health is so much more complicated. What other thoughts or questions do folks have?
I think just like a very, oh, I'm so sorry, Ray. This will be really quick, but just thinking about putting out small fires whenever the people at the clinic would knock on your door and ask you to come talk to the patients who were recently diagnosed. What do you think were some things that were very effective in that moment to help them get through that news?
Yeah. You know, it's so interesting. The person who really like spawned this idea, I don't think he has any idea like where I've taken this, but you know, one of the things was like actually education, because I think there's still so much like misinformation, even among people who like should be getting good information. So it was sort of like, hold on, like, you're going to be okay. You're not dying tomorrow. There are good medications. This medication will keep you alive for another 30 years. You're already like, you know, whatever, 50 years, you're already in your mid 30s. Like, you're going to live to your mid 80s. But then also it's just basic like coping plan, right? So someone's in acute distress. They've maybe not experienced news like this before. And often we're having like a really intense distress reaction with like, you know, everything. So it's like setting up a coping plan, following up with them after that. So I would often like literally write down like, what are you going to do to help cope? Is there one supportive person you can tell who can like be an outlet for you? So trying to get them to build support in their life, and then following up like pretty consistently with them. Like calling a few days later to see how they're doing, getting the nursing team involved. I think in an integrated setting, you also have like the benefit of working with other providers. But what really sort of surprised me about some of those experiences was that from a database perspective, like, I had already worked with many databases where you could predict who was going to get HIV like numerically, right, as a student. And so they're telling me about their habits, like how often they're drinking until they black out, how many sexual partners they're having a week. And I'm thinking, this is like someone who is very high risk. Like, their odds ratio is like, you know, multiples, like a 10.5 or something. And they're experiencing this news as a total surprise. And like, that to me was like a whoa. I thought for sure that people would be like aware, right? And so I think that's the piece, is like giving good education up front and also personalized feedback on risk. But then once someone is going through that, I think just like with any other illness adjustment, right? There is an adjustment. There is like a lot of like acceptance work that can be done. You know, a lot of support that can be provided. And what was so beautiful about that clinical story is that person ended up doing like fairly well. He was able to get on SSRI, which helped put the floor under him in the meantime. Was able to sort of like cope and deal through individual therapy, ended up joining like a group at his work where they like supported HIV advocacy stuff, ended up getting into a relationship. Like it like all worked out very nicely, but that very initial phase was really, really dark. And I think that's also really important to keep in mind if you're working in a health setting, is like sometimes you're meeting people at that like liminal phase where they're trying to sort through like what is happening in their life. And so sometimes just like being able to help be that support and guide them. And then also saying like, you know, as I've done it more and more, what I often say to people now is like, this may be your first time going through this, and that is really hard. And I'm going to assure you that it's not my first time walking someone with someone who's going through this process. And so hopefully if you have questions or like you don't know things, we can connect you to the right people. And like, I've worked with other people, they've gotten better, and sort of being that hope for them.
My question will be, I'm curious about your experiences working with different stakeholders, policymakers. What has worked, especially thinking about your experience working in medical field. Well, I always feel like as for psychology, we're on the lower end of the hierarchy, and oftentimes when people make medical decisions, they don't involve the psychology perspective. Like, what do you think? Like, as we as psychologists in the future, can provide our unique perspectives, and what are some of the ways that we can give at least some of those messages into the system and get people's attention?
Yeah. So I think this has been something I wish someone talked about in training more. Like, I don't think anyone while I was in graduate school told me what you just said, which is like, you're going to get into this place and people are like, what does a psychologist do? Why are you here? And like, what can you bring? Right. So I will say show, don't tell. So I show people my value. Like, I don't need to tell them my value. And so I actually earlier today, I'm doing like a little bit of a quality improvement project where I am at BMC. And I was talking to a PCP who works with patients with substance use, and I was asking for her feedback. And she basically said, reading your clinical assessment and your initial evaluation was so helpful to me. Like, I would have never known the information I needed to know, but you really spent the time and like spelled it out. And by the time I got to end of reading your note, I knew I wasn't going to continue that medication for this person, right? And so it wasn't me saying, hey, I'm a psychologist, it can be really helpful to you. It was them seeing my note and being like, you need more of that. Can you get people like that into our clinic, right? And so I think that would be my advice, is like, show people what your worth is. I think we are highly trained in identifying mental health conditions and identifying a diagnosis and a treatment plan in a really like quick amount of time. We're taught to think holistically about a person. We have more training in cognitive, right, areas and sort of ruling out medical versus cognitive versus psychological stuff. That can all be super helpful in like a fast-paced medical environment where often someone's just like, I don't know, what's your need today? So just taking that time and really developing those skills, I think that's probably I would say like the number one skill that I think I bring, is that like ability to sit with someone, get a good picture of what's going on and come up with what I think would most help them. Which I think other mental health professions certainly have some of that, but I think as psychologists, we get a lot of practice with that. And then I would say also acuity. And I think as a health psychologist, I didn't see as much acuity, but I think people who are trained as clinical psychologists often have worked in state hospitals or inpatient units or partial hospital programs, right? And so you're used to seeing high levels of distress and high levels of psychopathology and are able to know what that is. One, what medication someone might respond to, which is very helpful for the prescribers. And three, what you would do therapeutically to help support someone with those conditions, which is different than just sort of offering support to patients. So that would be show your worth. That would be my take home.
Thank you. A wonderful sentiment to end on, right? That, we really have a great insight into the population you work with, Dr. Rogers, and also the way that in your role you advocate for your patients and for your role, right? And really providing this comprehensive safety net for folks and helping improve their mental and physical health outcomes. So we're very grateful for your time today. Thank you so much for joining us. It's been wonderful.
Thank you.
Thanks.
Thank you.
Thank you.